Good morning. I think everybody knows me by now because I've presented enough M&Ms here that I think it's appropriate that I'll be talking about M&M. So I have absolutely no disclosures with this talk. I don't do any research. I don't have any funding of any form. So over the past 4 years since I came here from the University of Colorado as a second-year resident, I probably stood up at this podium close to 30 times. I've presented some pretty rough M&Ms. I've confessed to a lot of bad errors. Some of them are just judgment, some of them were technical, some of them were out of my control. But I've definitely come before a surgical jury here, and as a result, I've come out much better for it. I've learned innumerable lessons here, standing at this podium, and luckily today, I hope I don't learn any lessons because I'm not presenting any M&Ms. I'm actually happy to just be talking to you guys about M&M. So I want to go ahead and just go ahead and provide you guys with a brief history of M&M, how it kind of came to be, and how it ingrained itself in surgical culture. So the beginning of M&M starts with kind of an era where quality wasn't that important. Surgery was just starting to evolve as anesthesia was getting better in the late 1800s. I wouldn't call it better. I mean, it was just kind of starting to exist. I mean, I don't know if anyone would call it ether good. But this is an era where the outcomes of our operations weren't that important. It was just a matter of whether or not they were completed. But as we worked our way into the 1900s, things started to change. And a lot of that was by a provocative and very accomplished surgeon who was truly a pioneer in quality assurance and surgery all around, Dr. Ernest Kaufman. So Ernest Kaufman was born in the late 1800s. He was raised in the Boston area. He came from a very privileged family. Nonetheless, he went on to do his undergraduate training at Harvard and then went on to do med school at Harvard. His first contribution to healthcare actually wasn't in surgery. It came in anesthesia. So as a third-year med student, along with his friend and classmate Harvey Cushing, he was a bit dismayed by the state of anesthesia at that time. Both he and Harvey Cushing had their first patients that they administered anesthesia to die, and they thought maybe there's a better way. So the first thing he ever really contributed to the medical society was what they call ether cards. So he and Harvey Cushing developed a card. It's a simple record of patients' vitals, the drugs that were given, and their reaction. And interestingly enough, this has now kind of evolved to the modern form, or this predates the modern form of the anesthesia record. Not much has changed. So it's pretty remarkable. And this was all, really his first act of helping move quality assurance forward. He ended up finishing medical school in 1895. His first position within the MGH community actually wasn't as a surgeon. He was hired as a skiographer, which is a radiographer at that time, where he studied radiographs as this was kind of new and coming into the medical field. He actually went on to publish the first atlas of skeletal surveys. So that was kind of an interesting accomplishment that he had before he ever became a surgeon. He started his surgical practice in 1900. And in his first 10 years of practice, he produced several papers, more than 30 actually. He had established himself as a renowned ulcer surgeon, although we don't really ever talk about him for that. He also established the first bone sarcoma registry. This is important because this is actually considered the precursor to NSQIP now. But during that process, he was using written medical records, which is also something that wasn't really a thing at the time. So in 1905, he had established the first bone sarcoma registry. And during this course, he came up with an idea. He called it the end result idea. So the end result idea is really it's not really a novel concept. It's something that we would be shocked to hear didn't exist, but the idea was that every surgeon, every hospital should follow patients, look at the outcomes from the treatments we provided, whether it's surgical or not surgical, see if they were successful, and then figure out why not. And the whole goal of what he wanted to do was just to prevent recurring issues that could be prevented. And he did this at multiple levels, both as an individual and at the systems-based level. He went ahead and pushed his ideas throughout the MGH community, and they're actually not well received. They weren't well received at all. There was a very hierarchical system there. in which outcomes weren't really that important. Seniority was more important. And so he was a bit frustrated with the system. He maintained his appointment at MGH, but ultimately broke off and started his own hospital. Interestingly, it was just across the street. And at this hospital, he was able to implement his end result idea. And he did this by using just note cards. These are called end result cards. So he would keep these cards on his patients, and it would have some basic demographics, some information about his operation, and any complications that they had. He would follow his patients for a year. That's what he thought was sufficient to determine what the outcomes were. And interestingly enough, on this card, he had a shorthand system where he actually classified all of his errors. And these are the 6 calamities of surgery, as he called them, that he used to classify his errors. Interestingly enough, a lot of these are things we consider errors that we would classify today. Knowledge, surgical judgment, those are probably the most frequent things we talk about up here. He may have been a bit ahead of his time, talking about lack of care equipment. Now that we're in an era where we have quality metrics and we're going after more systems-based problems, this is something that's kind of remarkable to think he had already started incorporating into his errors back in the early 1900s. Lack of diagnostic skill. This is probably something that's less important today just because our diagnostic capabilities are so much better. Something that we probably don't have to deal with as much. Patients' unconquerable disease, our staging, our ability to decide patients need surgery or not, or they're going to benefit from it, has changed a lot. And then, of course, patient refusal for treatment. So he continued to publish about his end result idea, and he started to publish things that were coming out of his hospital. He did this, again, really kind of through 1910, 1911. And in 1911, the then president of the North American Surgical Society reached out to him because of his work with the end result idea. And he asked him, in addition to 2 other surgeons, to try and found the American College of Surgeons. Now, Dr. Kaufman's role in this was actually to chair the Committee for Hospital Standardization. And through his committee, they came up with 5 basic principles and standards that hospitals should maintain in order to pass the upcoming ACS surveys. These seem pretty simple, but at the time they were kind of shocking. So each hospital needs to have a medical staff. I think that's pretty straightforward. The members of every medical staff need to be chosen based on merit. This was a really strong point that he made, just because he felt that a lot of what went on at MGH at the time was not based on merit. It was, again, just based on seniority and authority. Number 3, there should be regular staff meetings to review cases, or in his case, end results. Number 4, medical records need to be written and filed for patients. I guess they didn't have Epic. And then each hospital needs to have a clinical lab and radiology section. So, of all these 5 things, the third one's probably the most important, because this is really the first suggestion of a mandatory case review, or M&M. Interestingly enough, the Committee for Hospital Standardization still exists today. It's just taken a different form. It's now known as the Joint Commission. So for the residents who don't like M&M and the residents that don't like when JCO comes, you can thank Dr. Kaufman. All right. So Dr. Kaufman continued to work on the Hospital Standardization Committee. He continued to run his own hospital, and he continued to voice his feelings about the need for following our results and establishing outcomes data in the Boston community. Again, this wasn't well received. The Board of Trustees never really took on to this at MGH. In 1914, he kind of created a political frenzy, and he actually wrote a letter of resignation to the Board of Trustees at MGH, saying that he didn't want to be part of the group anymore, essentially because of the seniority system. The following day, after his resignation was accepted, he then wrote another letter saying that he would like to be the chair of the department because his outcomes are superior to everyone else's. I don't think they got back to him, but anyway. So a year later, he was continuing to try and stir things up, and at a local surgical society meeting, which he was the chair, he went on to present a cartoon which made everybody in the medical community upset. It ended up actually kind of shunning him away from academic surgery altogether. So here's the cartoon that he presented. This was actually on a 6-foot poster. So I'll do my best to kind of explain it. I think I have a pointer.
Yes.
Back here, you have a little man standing on a bridge. This is supposed to be President Lau, the president of Harvard University at the time. And he is pondering as to whether or not the Harvard teaching faculty could ever make a living without practicing on the riches of Back Bay. So Back Bay is supposed to represent the ostrich. Now the ostrich is sitting there with its head in the sand, and there's a quote next to it reading, "If I only dared look and see, I might find a doctor who could cure my own ills." While over on the screen left, you can see the Harvard and MGH staff only interested in the golden eggs. And then over to the screen right here is the Board of Trustees. And there's a statement next to them that says, "If we let her know the truth about our patients, do you suppose she would still be willing to lay?" Okay? So,
job ending.
yeah, and it was. You got it, right? So people didn't even stay in the meeting. People walked out. Dr. Kaufman's close friends wouldn't even talk to him after this. He was then, basically, he lost his remaining appointment as teaching faculty at Harvard. He was forced to resign from his chair position on the hospital standardization committee, and he's basically relegated to his own hospital. Now, he didn't stop, though. He then continued to go on with the end result idea, and he did something that was really groundbreaking. In 1917, he went on to publish the results that he had at his private hospital in the first 5 years. This was pretty remarkable, and it couldn't be done today because of the litigious nature of what we do. But he published his results, and he went through 334 cases. He published all of his complications. He then even went on to go ahead and get this publication to anybody who wanted it, basically. He made innumerable paper copies and actually distributed them to anybody who was a member of the American College of Surgeons free of charge. Again, if this were done today, the 334 cases would probably result in 334 lawsuits. So this is kind of like the last point in time where we see a lot out of Kaufman in regards to pushing the end result idea and quality assurance. He definitely continued to publish and kind of promote his work, but things kind of go quiet for a while. He ended up joining the military in World War I and served, and at that point, some of his things stopped, but he used end result cards on all of the military that he took care of. He unfortunately didn't really come back to the academic surgical community until about 1929 when Harvard gave him his appointment back, but it was really just to work on the bone sarcoma registry. So things get kind of quiet for a while. It's not until 1935, by way of the Philadelphia Medical Society, that a group of surgeons and anesthesiologists formed a meeting in which they would come together and they would review anesthesia mortalities. This was kind of the first of its kind. This is probably the first true M&M. That's a little bit different than what we're used to today. This meeting was actually facilitated to promote reporting, and the reporting was done in such a way where it was anonymous. Now, the way these cases were discussed was also anonymous, so it allowed people to actually discuss the unfavorable results that they had in a non-hostile environment. Now, if you read about accounts of this meeting and how it evolved, there actually were numerous surgeons who would actually just admit they were the surgeon involved or the anesthesiologist involved. People actually did want to own up to their mistakes, which is pretty interesting. They evolved a little bit. In 1940, they changed their name to the Anesthesia Study Commission. They kind of expanded who could be involved in the meeting. So any physician in the community could join. This included residents, interns, and medical students. And this is probably the first evidence of this M&M process being introduced to education. They also changed what they did. They went ahead and they reviewed more than just mortalities. They reviewed complications as well. Again, the culture of this meeting maintained itself. Everything could be reported anonymously, discussed anonymously, but there was a trend for people to just speak up and kind of own their mistakes in an attempt to go ahead and betterment the care of their patients. In 1945, the group published their results after the first 5 years of meetings, and they produced some pretty astonishing information here. So in Henry Roof's publication for the commission, they revealed that 2/3 of the cases that they reviewed that were anesthesia mortalities could have been prevented. After this big event, not a lot happens in the way of at least historical landmarks on paper for M&M. The next big thing to happen on paper occurs in 1983. 1983, the ACGME issued a mandate that all residency programs must hold scheduled conferences to review complications. Now, this is kind of a loose requirement, and it still is. If anyone goes to a medicine M&M, it's not the same thing. I mean, it can be a glorified mini grand rounds if you want. So, how did surgeons start doing this? Well, the answer is they'd already been doing it. And we can see this as evidenced in a lot of different forms, but mostly in a couple of literary works. Probably, in my opinion, the most important one that we can kind of use to look back and kind of see the culture of M&M, which is a book called Forgive and Remember. Now, I think a number of people in this room have probably read this book. For some reason, surgeons like to read a book by a sociologist. It doesn't make sense to me, but it's an interesting book. It's written by a man, Charles Bosk, who's still an active medical sociologist out of Penn. He wrote this as a graduate student. This was his dissertation. And what he did for this dissertation is he took on the role of ingraining himself on an academic surgical service for 18 months. This all took place in the book at a place called Pacific University. But I think it's well known, common knowledge, that this actually was at the University of Chicago Hospital. And interestingly enough, there were still some people that were involved in this book practicing when I was a medical student. So that's, what, 6 years ago? Now, what he did is he basically did what a medical student would do now if we didn't have all of these rules and regulations. He was at the hospital before residence. He rounded with the residents every day. He joined all the conferences. He scrubbed into cases. He retracted. He was there before everybody, and he left after everybody. So he truly immersed himself into the surgical culture. And as a result, he produced this dissertation, which focuses on how surgeons manage errors, but specifically how surgical trainees manage errors, and how it's used to both culture and indoctrinate surgeons into our professional society. So, one of the key concepts kind of at the end of this book is that M&M is not only a process for discussing errors and everything else, it's the process of how we socialize surgical trainees. So, probably not in this format. I've never felt like, I probably feel like having a drink after I present M&Ms, but yeah, I think attendings might feel that way too. So when we talk about socialization of surgeons, he talks about M&M as a ritual, and we'll talk a little bit more about what that means. He talks about it serving a purpose to establish what errors are acceptable, basically establishing the norms of what we can expect from ourselves, but also what we can't expect from ourselves. And then something that's a little more outdated is it establishes hierarchy, which expands the culture of M&M and also the culture of an academic program. So, the ritual. So M&M has, in many ways, become the most coveted ritual in surgical education. I mean, it's a time every week where our clinical duties are put to the side, although most of us still continue them. Everybody in the program is expected to be here, and we all sit in the room at the same time and talk about a common topic. It's pretty remarkable when you think about it. We get all these people here who have so many different priorities, different things to do, and everyone comes together, they do it, and it seemed kind of as almost like a religious practice. Now, the ritual itself is something that both the attending associated with the case and the resident presenting engage in. And Dr. Bosk refers to this for the resident as putting on the hair shirt. Hair shirt's a garment, apparently, that's worn for repentance. Looks quite uncomfortable. I found this picture on Etsy, so if you want one, you can probably get one. I still don't know what Etsy is, but anyhow, wearing the hair shirt serves a purpose for residents. Okay? And he describes it as the process of teaching surgical trainees self-culpability. Now, some people might argue that this isn't so much the case anymore because the things we talk about are a little bit different. We don't necessarily take blame for everything we do at M&M anymore, but for the most part, it's still kind of a cultural norm that we stand up here and take responsibility for something, whether we've done it or not, and we learn from it. So, in regards to errors. So this book establishes that errors are expected and they are acceptable. We want to be perfect, right? We're in an era of metrics medicine now, where the expectation is perfection, right? But in this book, it clearly establishes that we can't do what we do without mistakes. Our field is dangerous. And much like Dr. Kaufman, he came up with his own classification of errors. Now, these are a bit different than Dr. Kaufman's. This is a different time. This is the 70s. But first is technical errors. Second is judgment errors. These were the same ones that Kaufman had at the top of his list. There's two additional errors which we probably really can't recognize today, which are normative errors and quasi-normative errors. Now, these occur in residency, in our training, but they're not something that we publicly discuss at M&M. So normative errors are acts of omission or failure to, fulfill a duty to a patient. Do they pick up the phone? Were they able to work with the nursing staff? Do they cause some other calamity just by a result of their character or their own personal deficiency? Quasi-normative errors are not even close really to what normative errors are, but they're errors that shape perception about residents. Quasi-normative errors are errors that are specific to a service or an attending, something that sometimes can come up in M&M, but again is probably a little bit outdated for our purposes. So when we compare this to Dr. Kaufman's, it's pretty interesting because really he just talks about the technical errors and the judgment errors. And in many regards, that's a bulk of what we talk about today. Now, things that have been integrated, and I think that Dr. Kaufman was kind of on top of, is that he'd already kind of acknowledged that there are going to be systems errors somewhere in here, like lack of care equipment, lack of diagnostic skill, there might just be a lack of diagnostic capability. And then, of course, Dr. Kaufman, involves a couple of things that may be outdated as well. But it's interesting to see this concept. So many of these errors have gone away, and we've now added in these normative and quasi-normative errors. And I think the reason for that is because now we're talking about M&M in a educational context. It's not the same thing as we're going to have an anonymous meeting with a bunch of practicing physicians and bring them together. So I think this is where the normative and quasi-normative errors find their way into this idea about how we classify errors at M&M in a surgical residency program. So in his book, the book's called Forgive and Remember, so I have to at least touch on that. Technical errors, they're all forgivable. Judgment errors, also forgivable. The caveat with these, technical errors, they need to be recognized early, and they need to be acknowledged early and dealt with early. You can be forgiven for a technical error, but you can't be forgiven for it more than once. Judgment errors, full disclosure results in forgiveness. Okay, as long as someone can explain what they did, why they did it, they can explain that it wasn't an error of omission and that it was all directed at the patient's betterment, these can be forgiven as well. And those actually are usually the most educational errors to talk about. And then normative errors. Again, these are probably outdated. I don't think I've ever seen any of these really brought up in a public forum here at UC Davis. And he attributed these to personal deficiencies or issues of character. When it comes to the quasi-normative errors, he refers to them in the same way, but he also describes it as acts of being insubordinate or having too much hubris. Hierarchy. This might be a little bit outdated, but he basically states that it's the commentary in the room, who talks, when they talk, and how they talk about things that establishes the hierarchy between junior and senior faculty. He then extrapolates to include this about the structure of the actual residents themselves, between chief residents, junior residents, and interns, and even the medical students. This is a little bit outdated because anybody can talk. While the residents here, we probably don't open our mouths that much. It might just because we don't have as much to say. And then he also developed the concept that seniority establishes norms. I think this is kind of gone. Now that we have evidence-based medicine that people can challenge, people are a little bit more careful about saying what the norm is based on their experience. So in summary, I think that we look at Forgive and Remember, and you can kind of refer to this, and it just gives us great evidence that there was already a naturally ingrained process by which surgical education programs had already integrated morbidity and mortality conference into their curriculum. It really has silently become the cornerstone of surgical education, and it happened without any mandates or anything being forced. And this all goes back to, I think, the change in 1940 when the Anesthesia and Mortality Committee turned into the Anesthesia Study Commission, and they opened all doors to all physicians and started incorporating residents, interns, and medical students. The last thing he established is that there's the need for intense socialization of surgeons. And I think this is still true. I think that the process of coming into M&M, learning the format, learning how to stand up here, present our mistakes, some of them worse than others, is absolutely necessary for us to develop the humility that is necessary to be successful in this field. There's other evidence of this already being a well-cultivated process that comes out of a book written by a surgeon who's still I think, practicing, from what I hear. Leo Gordon. This is something that's probably more directed for residents, but he has a very good excerpt in his book talking about a patient called Richard Yee. So this is Dr. Gordon's first operative case. It's also his first M&M. And in the book, he describes being at a Boston training program in the late 70s, showing up on his first day of internship and within an hour being told he needs to go to the operating room to go do an appendectomy with his resident, Dr. Rankin. Now, it's significant to note Dr. Rankin was an intern 8 hours earlier. The anesthesiology resident was an internal medicine intern 8 hours earlier. The way they describe the room is almost like a horror scene. The anesthesia resident is sitting there with a book propped up saying, it says, Intro to Anesthesia, the Management of Drips. Okay? Quite unsure of himself. Dr. Rankin is just as blind as Dr. Gordon. He's taking him through the case, which really means figuring it out as you go along. And during the case, everything is just described as being horrific. The patient's moving, the patient's rigid, the patient is bleeding from things that they haven't really identified what they are yet, tissues being removed. At the end of the day, though, they got the patient out of the OR. They thought they removed a tubular structure, and the patient survived the anesthesia. So that sounds good. He then went on to develop a pelvic abscess, a small bowel obstruction, and he required 2 additional operations after an 11-week stay in the hospital. And at the time of discharge, he walked out with an ostomy on the cecal fistula. So Dr. Gordon got to present this M&M as an intern, and this is his description. He reads, I knew nothing. I knew few of the important details of the case, of the operation, or of the approach to any of the problems that the patient experienced. It was the most humiliating and demeaning experience of my life. I came to realize that the template for presenting successfully at the meeting was the same template for the acquisition of all surgical knowledge during residency. The template consisted of preparation, anticipation, and library research. Preparing for surgery and clinical work became intimately related to preparing for this weekly meeting. My ignorance and humiliation were cathartic. So I think everyone in this room probably has their own Mr. Yee. I think I have more than a couple, more than I want. But I think that this really is a good evidence being written of an experience in the 70s that this is, M&M's been around for a long time, and in reality, it hasn't changed that much. Now, I think we can all argue that it's probably far less malignant, if not malignant at all anymore, but the concept's the same, you know. We still stand up here, we present our sins, we put on the hair shirt. The things we present are relatively the same. Some things that are different is we've now kind of gone into this era of quality metrics. We present systems-based issues. We present retained lapse in a sense that it's not necessarily just the surgeon's fault anymore. So some of the self-culpability that Dr. Voss talked about has gone away. But interestingly enough, not a lot has changed in M&M in the format or any requirements, at least on paper, since the 1980s. Now, I already realize I've submitted a form of this talk where I'm missing 2 slides, but I want to just talk about 2 things that are on this timeline that kind of come down the road. In 1999, we see the report To Err is Human, which was produced by the Institute of Medicine. And this was kind of a groundbreaking publication because it basically made it very clear to the lay public that people die in the hospital from errors that aren't necessarily related to a doctor. It's just the system itself. They provided a really concerning statistic that 98,000 potentially would die each year just because of hospital mistakes alone. Now, this has pushed us into an era of quality metrics, and now we have all sorts of quality metric systems. A lot of academic surgeons who take a focus on education write about this, and they suggest that M&M needs to go in this direction where we start focusing on quality metrics. But this has been published for a number of years, and nothing really changes, other than the fact that now we talk about some systems-based cases. So on that note, I think M&M is going to stay around for surgeons. I think it might go away for internal medicine, even though there's a mandate. They can kind of do whatever they want with the general requirements. But I think it's necessary, and I think it's going to remain necessary as long as surgical practice exists. So I'm sorry, but I'm missing a summative slide. So on that note, I wanted to say thank you for tolerating my numerous M&Ms over the last 4 years. I've presented some pretty bad ones. I've learned a lot of lessons, and unfortunately, I think I have a couple more coming up.
So thank you, Adam. That was really great. And I think we should all just take a minute to be proud of the fact that it was surgeons. And really the American College of Surgeons has continued very strongly with this culture. I will say that not all departments have this traditional M&M still. Many think it's antiquated and not of value. They had gotten rid of it about 4 years before I left UCSF. They have their divisional M&Ms, but not a total department M&M. So I'd be interested in your opinion, and then some of the other residents, about whether you think this total group activity is still worthwhile. I got the hint from your talk that you think it is, but
yeah. So I think, obviously things are changing, but I think that the purpose of this talk, I think about what Dr. Bosk wrote. I mean, I read this book as a fourth-year med student, and it actually made me so certain about going into surgery, right? We're in this field where we're doing dangerous work, right? And part of being able to do that is learning how to handle mistakes. And I think that the fact that we come together as a single group with multiple opinions, where people aren't necessarily versed in one person's specialty versus the other, creates a really good process of inquiry. I think it forces residents to also be able to learn how to talk about it to other people and to kind of defend their decisions. I think when you do just a divisional M&M, you certainly are going to learn, but then you get into the quasi-normative errors that you address, right? Things that are specific to a service. So I think that maintaining this is absolutely crucial. It's also a lot more intimidating to stand up at this podium than it is to stand in front of a few attendings in your division and go through it. And so I think it's necessary. I think it's absolutely necessary for helping us develop as surgeons, dealing with wearing the hair shirt and learning how to handle our mistakes in front of a surgical jury.
Dr. Cook.
Very interesting talk, and I like the talk to have the history of surgery, because as Dr. Farmer points out, surgery has a vast history of quality and excellence, which it has to, because it's so difficult, and it's always good to learn from that. I guess a couple questions from you, again, as a resident's perspective. Have you ever been in a case where the attending asked your opinion about what to do next in a clinical situation? And if so, has the thought ever occurred in your head in regards to what your recommendation would be based on how this would look in M&Ms?
Absolutely. I've been quoted as saying, I think this will sound better on Tuesday morning. Not just once, probably numerous times. While my opinion might not necessarily matter as far as the judgment part of it goes, I think sometimes there is value to thinking, well, okay, yeah, you're right, this is how it's going to sound on Tuesday morning, and why is it going to sound that way on Tuesday morning? It's not about how it sounds, it's about what's doing right for the patient. And I think the thought process there is that whatever the consensus is going to be about what we do, if it's good on Tuesday morning, it's probably good for the patient, right? Because we're going to come together, we're going to have all of these minds together from different specialties, many from our own, and we're going to come to some conclusions about what the best course of action was. And I absolutely, without question, still do say, all right, how's this going to sound on Tuesday morning? I think this is probably the best thing for the patient. This is maybe how it'll sound, because it does drive us to think that way. And I think sometimes that's a very good thing. Again, we shouldn't just do things because of how it's going to sound on Tuesday morning, but it's definitely a point where we can force ourselves to engage in inquiry.
Do you want to call on some of your fellow residents?
Laura.
Thanks so much for your talk, and I agree it's a critical part of our learning. I'd like to highlight Jamie Anderson's research that just presented in the Pacific Coast. She talks about what the difference is between the patient safety reported outcomes and then what we present to M&M, and her result was we present unique cases, things that don't come up in these quality metrics, and so I agree that it's a really important part of our training.
That's actually a great point. Yeah, Jamie's helped some good stuff on this, and I think that it is good because the way we select our cases, it's done so that we can talk about cases in a case report format. The metrics that we talk about, they need to be talked about too, but it can have its own form. So I think maintaining this as surgeons specifically is critical.
interesting to hear that other institutions are going to more divisional-driven M&Ms. And it just kind of makes me think about some stuff that's happening in the wider world, and how people talk about echo chambers, and certainly every specialty has its own little biases and whatnot. So it's really interesting in this room, like today we were talking about CT surgery and vascular. We have a vascular surgeon and a trauma surgeon, and I think a bariatric surgeon all weigh in on those cases that are not in their specialty. And you kind of get out of that little echo chamber of your specialty in this room that you may not get if you don't bring everybody together.
Dr. Jerkovich.
A couple of comments. First of all, a wonderful summary of the history of both Kaufman and Boston's role in this. It's largely lost, the details of it, and that summary of it was spectacular. Best I've ever heard about the summary of those two really key sentinel events and the foundation of the American College of Surgeons, and for what it stands for, as Dr. Farmer said. So that was outstanding. Secondly, a brief comment, because we'll do more later this year, on how we at UC Davis have moved to more of the system design issue, is why you hear that fifth Tuesday from each of the divisions summarize what their results were for the year, coupled with their perspective on what the national trends are. That's our effort to add to an individual M&M, a system-based M&M, to look at how we're doing. That's the entire point behind it, is to move from just individual cases into that system base, but still keep it relative to everybody in the room. The final point that I want to ask your opinion on is this one. The point that you made regarding if you're ignorant about how to do something, you end up with complications, and then that drives you to prepare for the operation, prepare for the procedure, just like it drives you to prepare for M&M. There are many, particularly those that were raised on the old-fashioned M&M, that view that loss at M&M as a critical feature for not driving residents to read and prepare for operations. And I'm asking your opinion and your fellow residents' opinions on, is that true? Is the preparation for operations been lost because most of the time the attending is there and drives the bus, and it's never going to be an intern, a second-year resident doing the entire operation like it was in your case report? Has that been a loss because of the change in the way we practice?
I think it's very dependent on the resident, because I would like to say I read for every operation a lot. Doesn't mean I show up and do it like an attending would, that's for sure. But I think some of the things we do in M&M now are resulting in less preparation. I think it depends on the format from institution to institution. So M&M obviously is not the same everywhere. I came here from medical school. I ended up having to do a prelim year at Mayo, and then I went to do another prelim year at Colorado, and then I came here. So in 4 years, I was at 4 different places where I saw 4 different M&Ms, and the format changes. I think one thing that definitely changes in this institution is that our cases are selected ahead of time. At a couple of the other institutions, M&M's a little bit different. The chief resident of a service will organize all the cases. They can go through divisional M&M or they don't. Regardless, they all get submitted. And instead of having a premeditated selection process where we have 2 weeks to prepare a presentation and everything else, you show up the day of M&M, you know you're on that list. So I think that does a couple of things. First thing it does is it ensures attendance, right? Everybody's got to be there. If you're up, potentially, it's got to happen. And everybody that submitted an M&M is going to be reading regardless, right? Because if your name gets called, you've got to go up there and you've got to know about everything. You're not given a specific thing to talk about necessarily. You need to read about everything. So I think that itself can be attributed partially to the way we do M&M. I think this is definitely the trend where we have pre-selected cases in the interest of avoiding repetitive issues that we've talked about, or in the instance of trying to maximize the educational benefit and teaching points. That being said, I think that some of the absence of some of the more, I guess you call it malignant behavior or commentary, probably does take the pressure off of residents. But again, it's all really dependent on departments, because some of that malignancy still exists in other places. Luckily
Glad
not
to hear.
But I think lost a little bit. Always having an attending supervising you. I think I've been noticing it more as a 5th year because every time I go into an operation now, I'm like, could I do this with no one else here? Like, would I know where to put the ports, and would I know what the next step was before they show me? Because you don't really have to. You can get through a day, you know, kind of going along, and they just lead the entire operation if you wanted to. So I think we do, unless we take a lot of ownership over making sure we know what all the steps are, you can get through a day in the OR without knowing what the next step is.
I think this is some of the issue that's being talked about related to transition to practice. So why there are some places where people feel that they're not getting enough autonomy in their training to transition to practice on their own, and why the first year is so stressful in practice for almost everybody, just because, oh my God, like I'm the only one. If something goes wrong, it's me that is taking responsibility for it. And oh boy, do I wish I had paid more attention to clinic when I was a resident. Or that's usually the most common thing that I would say people that are in their first couple of years out of residency are making that decision for who gets the operation. And the other thing you notice is that people usually in their first couple of years of practice get lots of studies on patients, you know, like because you want more support for the decisions that you're going to make. We try, and this residency has a reputation of being a place where people are pretty ready when they finish. I think trauma is a place that works hard to try to sit on the side and let residents take a fair amount of leadership in what they're doing, but I think that this is a great discussion to have. I think you all know, too, the way attendings role model what they do. You know the attendings that study and prepare, you know, about each patient and about each case ahead of time, and you know attendings who don't do that as much, and so there's a lot of variation among all of us and among each of us at different times, and I think one of the things that elevates academic medical centers is that you are all watching us in terms of what we do, which keeps our bar high as well as you all make observations about what we do. I want to make a last comment about Kaufman. So he died in relative obscurity and was buried in a relatively nondescript cemetery in Boston, kind of no big deal. I think it was 2 or 3 years ago, I can't remember exactly, Dr. Cook or one of my colleagues who are even better American College of Surgeons fellows might know, but the college, in honor of this really great history of what we do, kind of had a special ceremony to sort of find his grave. Somebody found his grave in Boston, and they had a celebration to sort of honor this guy who had made such a contribution, but who at the time was a little bit cast out by his peers because of what's going on. And I thought that your the cartoon that you showed is an important thing to remind all of us about, you know, what really is the mission, why do we do what we do, and at the end of the day it really is about taking care of patients, and what a great privilege it is to do that. And it's not about the golden goose. At the other side, I think a lot of medicine has been captured lately. We all have to care about making sure we get fairly compensated for the work we do, but I think it's important to, when you see some of these things in the newspaper about sort of unscrupulous docs in certain environments doing things, it's part of our moral character and our moral responsibility to be the kind of physician that puts the patient first. So thank you for that great reminder and all the great work you've done over the course of these last 4 years with us. So thank you again. It really has been.